So first of all, thanks to the team to allow me to talk on this very interesting topic. Now, I'll start by saying that the vitreous is actually a dumping ground for intraocular inflammation. So you have the microbes, you have the microbial DNA, RNA, the microbial proteins, of course, the inflammatory cells, the cytokines secreted by them, chemokines, and in case it's a tumor, you have the tumor cells as well. So everything comes and collects in the vitreous, which is the reason why there are several indications for doing pars plana vitrectomy in patients with uveitis. We have heard several talks earlier on how pars plana vitrectomy is useful in a diagnostic, as a diagnostic tool, either in microbiology or in cytology, flow cytometry, ELISA, or chorioretinal biopsy. All of these are generally spoken about when we talk of vitrectomy in uveitis. There is also a discussion on role of optical vitrectomy when there are significant vitreous opacities that are affecting vision in a quiet eye. But in this talk, what I will be focusing on is the anti-inflammatory action of vitrectomy in patients with active intraocular inflammation. Now, there are several mechanisms that have been proposed for the anti-inflammatory mechanism of pars plana vitrectomy. These include removal of the inflammatory cells and their secreted cytokines, removal of the helper T cells, which prevents the non-specific activation of other immune cells, and removal of antigenic load from the vitreous, which further modulates the immunological milieu. And finally, in the post-operative period, it allows rapid clearing of the pro-inflammatory cytokines and better drug penetration. These are all the reasons that have been proposed as an anti-inflammatory tool for vitrectomy. Now, what are the objections to doing vitrectomy in active intraocular inflammation? Most of these are derived as an extrapolation from the recommendations for cataract surgery in uveitis. Generally, it is said that it's an inflamed eye. There's a risk of retinal breaks if we try to induce a posterior vitreous detachment. There's a difficulty in clinical assessment of the degree of inflammation or when there's a recurrence post-operatively, because the vitreous is no longer there for you to gauge the vitreous haze. And finally, it is very well understood that vitrectomy cannot cure the uveitis. So why do we still talk about using vitrectomy as anti-inflammatory therapy in uveitis? Now, to do this, we have to first define why do we want to do this vitrectomy. The main purpose is the faster resolution of inflammation. The focus is on the word faster. The same thing can happen with medical therapy as systemic therapy as well, but here we are looking for faster resolution of inflammation and reduced dependence on the medical therapy, specifically the corticosteroids, which come with their own set of side effects. Also, when there are significant media opacities that are unlikely to clear completely with systemic therapy, vitrectomy can have a role. However, it should be very clearly understood that there is absolutely no intention to replace the systemic therapy that might be necessary for the nature of the disease that we're talking about. For example, if you have a patient of intermediate uveitis due to sarcoidosis, you can clear up the vitreous by doing a vitrectomy and give the patient a faster improvement in vision and a faster resolution of inflammation. But that will not prevent the use of, say, methotrexate in the long-term period, because the nature of inflammation in sarcoidosis is that it has a chronic it has a chronic course, and that cannot be taken care of by just one vitrectomy. The other thing to remember is that we need to assess the patient carefully before taking the call. Avoid vitrectomy in eyes with hypotony, be it acute or chronic, unless you have noted a ciliary body membrane or we are planning to inject silicone oil. Then I try to avoid vitrectomy in pediatric patients because the response is very unpredictable. There's a high risk of hypotony, and there's a very early nuclear sclerosis which will need cataract surgery very soon. Then in most infectious uveitis, where the antimicrobial therapy can lead to rapid resolution of inflammation, unlike the smoldering kind of inflammation that is seen in most non-infectious uveitis, you won't like to do a vitrectomy unless, of course, you want to do a diagnostic vitrectomy in these patients. And finally, if there's a poor view of the posterior segment, if there's a one-eyed patient, it is always better to avoid vitrectomy in these patients. Then what can we do to modify the surgical technique when you are operating in an eye with active inflammation? Of course, we are all using small gauge vitrectomy now with 25 or 27 gauge vitrectomy. These, the mechanics, the dynamics of these instruments is such that there's very little traction on the vitreous strands. Always use a sharp trocar. There's a very high risk of ciliary body detachment in an inflamed eye if you're using blunt instruments. Use relatively low suction and avoid sweeping movements inside the eye when the suction is on. Now, this is very interesting. Most of the objection to operating in a inflamed eye is about inducing PVD. But if you go into these eyes, majority of them will have a complete PVD. So you don't have to induce a PVD in these patients. In the remaining patients, there'll just be a stump that is attached to the disc, and this can be either cut at the disc itself or a gentle tug can be applied to the disc, and the remaining vitrectomy can be completed without any additional suction on the vitreous. Finally, I prefer to do an air exchange, just a partial air exchange, which prevents leakage from the ports. And remember, the main thing that I'm worried about in my patients with uveitis is the post-operative hypotony. And there has to be an absolutely low threshold to suturing the ports at the end of the surgery. These will tend to leak very much, unlike the non-inflamed eyes. So very low threshold to suturing the ports. The outcomes have been documented in various studies. While there are a large number of studies that have discussed the role of vitrectomy as a diagnostic tool, the anti-inflammatory role has been discussed in very few studies. Now, one of them is a landmark study, this one from 2005, which was a review of 44 intervention case series. And here, the visual acuity improved in 68% eyes. There was reduced inflammation and CME, and there was a reduction in systemic medication in 25 of the 44 studies. This one I find very interesting. The data from the SITE study, which included 849 eyes of 510 patients, past plantar vitrectomy was a very important predictor of remission of intermediate uveitis in these patients. And finally, we have one of our own studies where we did a case control study in 36 patients with bilateral TB uveitis, one of which underwent a past plantar vitrectomy. Now, in this study, at 1 month post-surgery, the eyes with vitrectomy had a faster resolution of the posterior segment lesions and a greater improvement in visual acuity. This is one of the fundus photos from that publication, and you can see the right eye in this patient received a vitrectomy, and you can see at 1 month the vasculitis over here has nearly disappeared, which can be seen here, while the non-vitrectomized eye has not resolved as much, and there's a new lesion which has increased in size here inferiorly. So this was, a case control study in the same patient where one eye received a vitrectomy. To summarize, the anti-inflammatory therapy of PPV needs to be explored further. There is faster resolution of inflammation, faster improvement in visual acuity, and reduced dependence on steroids. And we need to set very clear goals of the purpose of surgery and modify the surgical technique to operate in an actively inflamed eye. We must, however, remember that this does not alter the course of disease in any way, and the need for chronic immunosuppressive therapy still remains. Thank you for your attention. And this is an invitation to our uveitis course, which starts next week. Thank you again.